Hello, my name is David Berg, and I am a cardiologist and an intensivist in the Division of Cardiovascular Medicine at Brigham and Women's Hospital. Today, I'll be talking about acute coronary syndromes. There's my brief bio and my disclosures. So here's a roadmap of the ground that we're going to cover today. I'll begin by providing an overview of acute coronary syndromes, including definitions, contemporary epidemiology, and the use of high-sensitivity cardiac troponin assays in the diagnosis of patients with ACS. We'll then spend some time talking about management approaches for the two main classes of acute coronary syndromes, namely non-ST segment elevation acute coronary syndromes, which includes both unstable angina and NSTEMI, and then we'll move on to ST segment elevation myocardial infarction. And finally, we'll end with a brief discussion of cardiogenic shock and cardiac arrest, two important complications of acute coronary syndromes, and that are obviously germane to the management of patients in an intensive care unit. So broadly speaking, acute coronary syndromes can be divided into two main groups, namely non-ST segment elevation acute coronary syndromes and ST segment elevation acute coronary syndromes. The clinical presentations of these two entities may be highly similar. Patients often present with chest pain that may radiate to the shoulder, to the jaw, may be associated with breathlessness, nausea, diaphoresis. But the underlying coronary pathobiology is generally distinct. And so in the case of non-ST segment elevation acute coronary syndromes, there's some disruption of an atherosclerotic coronary plaque, either through plaque rupture or plaque erosion, that leads to in situ thrombus formation. And that coronary thrombus is flow limiting, but not completely occlusive of the coronary artery, which results in subendocardial myocardial ischemia distal to that stenosis. And that manifests on the electrocardiogram with either ST segment depression or T-wave inversions. By contrast, in the case of ST segment elevation acute coronary syndromes, the coronary thrombus expands such that there's complete occlusion of the coronary artery. The result is transmural myocardial ischemia, which manifests with ST segment elevations on the electrocardiogram. And so that's the major distinction clinically, is the electrocardiographic appearance. In addition, when we evaluate patients with potential acute coronary syndromes, we measure biomarkers of myocardial necrosis, and the most commonly used one is cardiac troponin. And so patients with ST segment elevation MIs will have elevated cardiac troponins after enough time, but not all patients with non-ST segment elevation acute coronary syndromes will have an elevated troponin. And so we distinguish among those among non-ST segment elevation acute coronary syndromes as being either troponin positive, in which case we call that non-ST segment elevation myocardial infarction, or troponin negative, in which case we call that unstable angina. So a quick word about contemporary epidemiology of non-ST segment elevation acute coronary syndromes and STEMI. These are data, registry data from California between the years of 1999 and 2008. And so the data are about a decade old at this point, but the trends that were first highlighted in this analysis have become more apparent or more prominent over time. And what the investigators reported is that there was a steady decline in the incidence of myocardial infarction over this 10-year period, which has been attributed to increased use of preventive pharmacotherapies like lipid-lowering therapies and decreases in certain behaviors like smoking. However, if you break that down by STEMI versus NSTEMI, the incidence of ST segment elevation myocardial infarction steadily declined, whereas the incidence of NSTEMI actually remained relatively constant. There was actually a brief uptick over this 10-year period. And so what we've seen over time is that the proportion of acute coronary syndromes that are accounted for by NSTEMI has actually increased, and the proportion of acute coronary syndromes accounted for by STEMI has decreased over time. Another way of defining acute myocardial infarction comes from a document known as the Universal Definition of MI. And this document is now in its fourth iteration and was developed to try to standardize the diagnoses or the language that we use to diagnose myocardial infarction. There are 5 subtypes of myocardial infarction, and clinically, we typically talk about the first 2, type 1 and type 2 MI. So I want to spend a little bit of time talking about the clinical features of those two and what makes makes them different. Importantly, myocardial infarction is defined by a rise and fall in cardiac troponin associated with symptoms of acute myocardial ischemia, new ECG changes, or imaging evidence of myocardial ischemia. But the underlying process is the one that I've been talking to you about up to now, which is that there's a primary coronary event. And typically that's either a coronary plaque rupture or a plaque erosion that results in in situ thrombus formation and partial or complete occlusion of a coronary artery. So the fundamental driver of myocardial infarction is that there's an acute coronary process. Type 2 myocardial infarctions share many of the same features as type 1 myocardial infarctions. They're characterized by a rise and fall in cardiac troponin. They're associated with symptoms of acute myocardial ischemia and ECG abnormalities. But fundamentally, they are related to an imbalance between myocardial oxygen supply and demand. And so that can occur through a couple different avenues, but often it occurs in patients who have underlying coronary artery disease and have fixed coronary stenoses that limits coronary blood flow or puts a ceiling on coronary blood flow. And then when there are either factors that either decrease myocardial blood supply or oxygen supply or increase myocardial oxygen demand, those fixed stenoses limit coronary blood flow further, and that imbalance results in myocardial injury due to myocardial ischemia, and that's what we call myocardial infarction. So some examples in the intensive care unit are a patient may be hypoxemic, which would limit coronary oxygen delivery. Patients may be anemic, or patients may have tachyarrhythmias, hypotension, hypertension. All of these can exacerbate that balance between myocardial oxygen supply and demand and result in myocardial injury due to acute myocardial ischemia. Other examples include coronary vasospasm, non-atherosclerotic coronary dissections, among others. And so shown here is the typical or the idealized cardiac troponin kinetics in patients with an acute myocardial infarction. And so when a patient presents with an acute myocardial infarction, at baseline, they typically would have troponin levels, which are markers of myocardial injury, that would be below the 99th percentile upper reference limit of a particular assay. As a consequence of acute myocardial ischemia, there's a rise in cardiac troponin levels, which occurs over the course of hours, and with higher precision assays, we're able to pick up on those increases earlier. And then there's a subsequent decline in cardiac troponin levels over the course of several days. By contrast, sometimes when we measure cardiac troponin, we'll see elevated cardiac troponin levels, but there's actually no change that happens in a cardiac troponin level over time. And so there are certain people who have chronically elevated troponin levels, and when they're not dynamic at all, that is often an indicator that this is related to chronic myocardial injury as opposed to an acute myocardial infarction. So there are a couple key things to remember in the evaluation of a person with an elevated troponin. One is that troponin elevation is not the same thing as myocardial infarction. Troponin elevation indicates myocardial injury, and when that myocardial injury is related to acute myocardial ischemia, that's when we call this a myocardial infarction. And so differentiating between nonspecific myocardial injury and myocardial infarction requires the clinical history and the electrocardiogram to demonstrate that there is, in fact, evidence of acute myocardial ischemia. The other important take home from this figure is that it's helpful to recognize that pattern of biomarker elevation, the rise and the fall that are characteristic of acute myocardial infarction as compared to the sort of tonic elevation that's seen with chronic myocardial injury. Now, depending on the specific sampling periods, you can imagine that it may not always be so super clear exactly what pattern is emerging, but that's why serial assessment of troponin ends up being so important. So putting that all together, if you have a patient who has an elevated cardiac troponin level, and we talk about being above the 99th percentile upper reference limit for the assay, the first question to ask, is there a rise and fall in the troponin? And if the answer is yes, and that's associated with acute myocardial ischemia, then you've established a diagnosis of acute myocardial infarction. And then the next judgment that has to happen is this related to coronary thrombosis, or is this related to oxygen supply and demand imbalance? And obviously, you don't have immediate information about the status of the coronary arteries in real time. And so that requires integration of other clinical factors that might be going on and that point us towards suspecting one etiology or the other. One important development over the last decade and a half or so has been the uptake of high sensitivity cardiac troponin assays, which are now the preferred assays recommended by professional society guidelines. And so there are a couple key take homes in comparing high sensitivity cardiac troponin assays with conventional assays. And some of this may be old hat if you use high sensitivity cardiac troponin at your site. But for those of you who still use conventional cardiac troponin assays, this may be helpful. So one thing is that there's a difference in the units between high sensitivity assays and conventional assays. High sensitivity assays use nanograms per liter, so the values are 1,000-fold higher compared to conventional assays. And when we talk about extensive myocardial injury and elevated troponin, that's exactly what we see, that the high sensitivity troponin assay will yield a value that's 1,000 times higher than conventional assays. But the other important difference is the performance of these different assays at lower cardiac troponin concentrations. And so with conventional assays, the precision when the estimates of cardiac troponin elevations are 0.01, 0.02, 0.03, 0.04 is much less good than it is for high sensitivity troponin assays. And whereas the high sensitivity troponin assays have greater precision for differentiating between normal and mildly elevated cardiac troponin levels. So there's a couple clinical corollaries of that and a couple things to keep in mind when you interpret cardiac troponin levels. And this comes from the ESC MI guidelines. So first, high sensitivity cardiac troponin assays have higher negative predictive values for acute myocardial infarction. And so if a patient truly presents with chest pain and has a undetectable cardiac troponin, it makes it much less likely the fact that the patient actually is having an acute coronary syndrome. And so with the greater use of high sensitivity troponin assays, the proportion of all non-ST elevation acute coronary syndromes that are related to unstable angina, which is troponin negative, has been decreasing over time. So that's an important concept. The other value of high sensitivity cardiac troponin is it reduces the troponin blind interval. So recalling the kinetics of cardiac troponin, there's a period where a patient is starting to have an ACS where cardiac troponin is not detectable. But because the high sensitivity assays pick up cardiac troponin levels earlier, we reduce that troponin blind period. And then as a consequence of this, we actually do detect more type 1 myocardial infarctions with high sensitivity troponin assays, which is the major reason that they've been adopted in practice. The flip side is that there's also an increase in the detection of type 2 myocardial infarctions. And so that's when the clinical judgment comes into play in interpreting high sensitivity cardiac troponin assays. Another comment is just that echocardiography or cardiac ultrasound can be an important diagnostic adjunct in the assessment or the initial evaluation of a patient with acute coronary syndromes. So sometimes there is a very clear story for ACS with characteristic chest pain, ischemic changes on ECG, and a rise and fall in cardiac biomarkers. And so the diagnosis is clear, but we all know that that's not always the case. And so echocardiography can help you out. And I think to understand the value of echo, it's important to remember the ischemic cascade. And that's to say that when ischemia occurs, the first abnormalities that are detected are perfusion abnormalities, as might be detected on a nuclear scan, followed by regional diastolic dysfunction, followed by regional systolic dysfunction or regional wall motion abnormalities. And then after that is when we see ischemic ECG changes and clinical symptoms. And so if you do an echo and you don't see any regional wall motion abnormalities, it sort of calls into question the diagnosis of acute myocardial ischemia going on. And that can help you sort out whether in fact this is an ACS or not. So now we're going to pivot a little bit and start talking about the management of non-ST elevation acute coronary syndromes, which, as a reminder, includes both unstable angina and NSTEMI. So one of the key developments in the pharmacologic management of non-ST elevation acute coronary syndromes over the last several decades has been the appreciation of that it's important to use antithrombotic therapy to prevent the formation and propagation of coronary thrombus, which we know is the fundamental pathobiology going on with acute coronary syndromes. And to do this, we target both the coagulation cascade using anticoagulant drugs, as well as try to inhibit platelets, which are obviously important mediators of thrombus formation in the coronaries. And so I'm going to talk specifically about the anticoagulants and the antiplatelet therapies that are most widely used and that are endorsed by professional society guidelines. Although the sheer number of studies in this area, it far exceeds what I can cover in this talk. So beginning with antiplatelet therapy, the backbone of antiplatelet therapy remains aspirin. So when a patient has a suspected acute coronary syndrome, it's critical to start them on aspirin with a loading dose of between 162 and 325 milligrams. And then patients are continued on a dose of 81 milligrams thereafter. In addition, a second antiplatelet is indicated for the management of acute coronary syndromes and NSTEMI in particular. And that includes the P2Y12 inhibitors. The 3 oral P2Y12 inhibitors, clopidogrel, ticagrelor, and prasugrel, all have a loading dose and then a subsequent maintenance dose. And I've bolded the ticagrelor and prasugrel to indicate that these are more efficacious for the reduction of cardiac ischemic events. And I'll show you those data in just a second. And that's why professional society guidelines prioritize either of those 2 agents above clopidogrel. A couple other notes about antiplatelet therapies. Historically, we tended to use a lot of glycoprotein 2B3A inhibitors, which target a different receptor on the platelets. But with more widespread use of P2Y12 inhibitors, the role of GP2B3 inhibitors has diminished over time. And that's because they are associated with high risk of bleeding without much additional bang for your buck. There are 2 clinical settings where we tend to use this. So that's when there's a coronary no reflow phenomenon, and that refers to once angioplasty is performed and an occluded coronary artery is opened, but there's actually not a return of coronary blood flow, or when there are thrombotic complications. So for example, acute stent thrombosis, that's an indication for GP2B3 inhibitors. IV cangrelor is an IV formulation of a P2Y12 inhibitor. It's generally reserved for when patients are not able to take oral P2Y12 inhibitors and is used while patients are actively undergoing PCI. Here's the data that compares the 3rd generation P2Y12 inhibitors, prasugrel and ticagrelor, with clopidogrel. There was 2 seminal studies that are now more than a decade old, the Triton-TIMI 38 study and the Plato trial, both enrolling many thousands of patients. And as you can see in the Kaplan-Meier curve shown here, prasugrel reduced the composite of cardiovascular events, of major adverse cardiovascular events, compared with placebo, with a trade-off of a small increase in major bleeding. And similarly, in the Plato trial, ticagrelor reduced major adverse cardiovascular events, again with the trade-off of non-CABG related major bleeding, which was an important distinction in the bleeding definition in that trial. But in general, the take-home is that both of these therapies are more potent for reducing ischemic events compared with clopidogrel. For years, we did not have any comparative data looking at prasugrel versus ticagrelor, but in the last couple of years, there was a trial called the ICERAC-5 trial that reported, which was a pragmatic trial. It was an open label trial comparing ticagrelor and prasugrel. And so there have been some methodologic issues raised about these results, but in brief, what the data showed is that there was a reduction in ischemic events in patients who were randomly allocated to prasugrel as compared with ticagrelor. And so current European guidelines, which are the only guidelines that have come out since this trial was reported, give a nod to prasugrel as the preferred agent over ticagrelor. And so a couple of things that come into play, though, when deciding between which of these agents to potentially use. Prasugrel is dosed once daily, and so for patients who prefer once daily dosing, prasugrel is generally the option. And because of these data that I just shared with you, there's a potential superiority with respect to reduction in ischemic events with prasugrel. So that's another reason you might favor prasugrel. On the flip side, based on the initial Triton-TIMI 38 study, there were a couple groups that were particularly high risk for bleeding with prasugrel, and those are patients in whom you might favor ticagrelor or even clopidogrel in some circumstances. And that includes patients who are very low body weight, patients who are older, namely above the age of 75, or patients who have a prior history of stroke or TIA. And then one final word that comes up often with antiplatelet therapy is whether or not to start antiplatelet therapy prior to coronary angiography. And the data in this with respect to this question has been mixed over time. And so the feeling in the cardiovascular community has shifted over time. But in general, the weight of the accumulating evidence at this point argues against routinely pre-treating patients with P2Y12 inhibitors before the coronary anatomy is known. And that's because particularly with contemporary stents, which have much lower risk of stent thrombosis, the added value in terms of reduction of stent thromboses and other ischemic complications is relatively minimal. And there certainly is an increased risk of bleeding with upstream loading, particularly when it's not clear whether a patient is actually going to undergo PCI or not. So in general, aspirin should be given right away in a patient who we suspect acute coronary syndromes, and then continue thereafter. The P2Y12 inhibitor, you should wait for the coronary anatomy to be known. And then if the decision is to proceed with PCI, that's when you load with the P2Y12 inhibitor. If a patient's being medically managed, they can be loaded with the P2Y12 inhibitor as well. So anticoagulant therapy, as I mentioned, is also important. The 4 agents that have been studied and are used in this context are unfractionated heparin, low molecular weight heparin like enoxaparin, bivalirudin, and fondaparinux. And in general, guidelines tend to favor unfractionated heparin, sort of the old sturdy tool that's been around for a long time. But this is the favored peri-interventional anticoagulant because of the ability to turn it on and off quickly, and with high efficacy. In contrast to the P2Y12 inhibitors, the anticoagulants are started immediately in a patient with suspected acute coronary syndrome, and then once the patient undergoes coronary angiography and undergoes percutaneous coronary interventions, if that's the case, that's when anticoagulants are turned off. If a patient does not actually undergo a PCI, then we typically continue anticoagulants for about 48 hours and certainly no longer than a week. One of the active areas is what is the optimal duration, long-term duration of antiplatelet therapy. And I would say there's been a lot of changes over time, and I'm not sure that we have a clear right answer at this point. So in the 1990s, we used aspirin alone. Clopidogrel was the P2Y12 inhibitor that sort of came on the scene around 2001. And that's when we started using dual antiplatelet therapy with at least 12 months of both. The data that I showed you demonstrated the greater efficacy with ticagrelor or prasugrel. And then, so we then started using 12 months of DAPT with aspirin and the 3rd generation P2Y12 inhibitors. And then there were a series of studies from around 2014 and 2015 that suggested that longer term use of dual antiplatelet therapy was associated with a reduction in ischemic events with the trade-off of increased risk of bleeding. And so where we are with current guidelines is they tend to recommend at least 12 months of DAPT, and then in certain patients, it may be considered to treat people with DAPT for longer periods of time. But because the increased trade-off, because of the trade-off with increased bleeding with this approach, there have been a number more recent trials that have looked at earlier discontinuation of aspirin, at least 5 at this point. And interestingly, the take-home from those trials is that continuing the P2Y12 inhibitor and discontinue aspirin actually reduces bleeding without an apparent increase in the risk of major adverse cardiovascular events. And so why that is still hotly debated, but what I anticipate over the coming decade is that we're going to move away from aspirin more and more, and that there's going to be a brief period that patients are on DAPT and then move to just P2Y12 inhibitor monotherapy. One question that comes up often is the optimal antithrombotic approach for patients who have an indication for anticoagulation. And the most common scenario is patients with AF who then are treated with a percutaneous coronary intervention. And what we've learned through a number of well-designed clinical trials is that the risk with triple therapy, dual antiplatelet therapy plus an oral anticoagulant in terms of bleeding risk is quite high. And so if we pull off one of the antiplatelet therapies, and typically aspirin is the one that we pull off, that we can significantly reduce bleeding risk without an increased risk of ischemic events. And so the default strategy here is a brief period of triple therapy while the patients are in the hospital, and then dropping the aspirin, and then patients continue on oral anticoagulation and single antiplatelet therapy. If patients that are particularly high bleeding risk, you may pull off all antiplatelet therapy after about 6 months. And if patients that are particularly high ischemic risk, triple therapy may be continued for up to a month. Other pharmacotherapies are obviously very important. We use anti-ischemic therapies, beta blockers, which are the anti-ischemic therapies that are associated with the greatest mortality reduction. The important caveat is that we do not give beta blockers if a patient has acute heart failure or cardiogenic shock, or if there's evidence of high-grade AV block. Nitrates can be particularly effective anti-ischemic therapies. Supplemental oxygen if a patient is hypoxemic, has an SpO2 that's less than 90%, but not just as a routine practice, which is what we used to do. And then the hospitalization for NSTEMI is often the time that we're focusing on secondary preventive measures, lipid-lowering therapies, heart failure therapy, smoking cessation, weight loss, cardiac rehab. And then more recently, we've been really focusing on initiating anti-hyperglycemic therapies that may be associated with cardiovascular risk reduction, such as GLP-1 RAs and SGLT2 inhibitors. And finally, colchicine and anti-inflammatory therapy, there's increasing data to support its use following ACS. A quick word about coronary angiography, and there have been a lot of studies that looked at coronary angiography in non-ST elevation acute coronary syndromes. I would say, to summarize that, the take home is that for most patients, an early invasive approach probably makes sense. And that's not an emergent coronary angiography aside from a couple cases. So the immediate or emergent invasive approach is required if a patient has hemodynamic instability or cardiogenic shock, refractory chest pain despite medical management, electrical instability, so they're having life-threatening arrhythmias, mechanical complications, or acute heart failure. Those are situations where you would take somebody straight to the cath lab, even if they did not have ST segment elevations on ECG. But in general, we treat people with medical therapy and then often wait for the next day to take them to the cath lab. I'll point out that the diagnosis of NSTEMI is when we use the early invasive approach. If somebody has a unstable angina, so troponin negative acute coronary syndrome, there's a role for use of non-invasive approaches for further risk stratification. All right, so we'll pivot now to management of STEMI. And STEMI, just as a reminder, the major difference between non-ST elevation acute coronary syndromes and STEMI from a clinical diagnosis standpoint is what the electrocardiogram shows. And so specifically, there has to be new ST segment elevation at the J point. The J point refers to the portion of where the ECG, where the QRS complex meets the ST segment. And you have to see ST segment elevation in at least 2 contiguous leads. Now, the magnitude of ST elevation depends, that meets criteria, depends on which leads are involved. So if it's the anterior precordial leads, V2 through V3, then there has to be a greater magnitude of ST elevation to qualify as a diagnosis of STEMI. And the specific thresholds depend on whether it's a man or a woman and the particular age of the patient. Outside of these leads, the diagnostic threshold for magnitude of elevation is greater than or equal to 1 millimeter. A couple diagnostic challenges come up. So the criteria that I just explained are the idealized scenario, but there are certain electrocardiographic patterns that make it notoriously difficult to interpret ischemia. And so this ECG is of a patient with a left bundle branch block. You can see the deep QS complex in V1 and the RSR prime complexes in V6 and 1 in AVL. And so in the 1990s, there was a fellow by the name of Scarbosa who came up with criteria for trying to interpret ischemia in the context of a left bundle branch block. And this is something you can always look up, but one of the key take-homes is that you're looking for ST segment deviations that are either concordant with the direction of the QRS complex, as we see in V2 and V3, and even minimal perturbations of the ST segment that are concordant can be suggestive of ischemia, or if there are discordant ST elevations that are dramatically discordant, so greater than 5 millimeters discordance from the QRS complexes, like we see in lead 3 in this example. Although Scarbosa developed these criteria for bundle branch blocks, there are a couple other scenarios where this applies. So ventricular pace rhythms, where there's RV pacing, recapitulates a left bundle branch block. And so the same approach can be used, or the same criteria can be used to look for a myocardial ischemia. Another scenario that comes up that may be demonstrative of an ST segment elevation, but is not apparent at first blush, is this ECG. And so here we see ST depressions in V1, V2, V3 with prominent R waves. And so that should make you think about a potential isolated posterior myocardial infarction. It should prompt you to get posterior ECG leads, which is what's done here. You can see that's indicated as V7, V8, and V9. And when in this patient we did this, we did in fact see ST segment elevations in those leads, which was diagnostic of isolated posterior MI. And then the final diagnostic challenge that comes up often, and it seems to come up often in the intensive care unit, is this pattern that we see here, where there's ST segment elevation and AVR, and then there's diffuse ST segment depression across a number of different leads. This can be a sign of ischemia due to left main coronary artery occlusion or multivessel disease. I'll say that this pattern in general is just suggestive of global subendocardial ischemia. And most of the time, this is not actually related to acute thrombotic coronary occlusion, but about 10% of the time it is. And so we have to be vigilant when we see this pattern about making sure that this is not actually what is going on with this patient. So in terms of management of STEMI, so in contrast to NSTEMI, where I started talking about pharmacotherapies and then added the potential role of revascularization, the opposite is true here, which is that the most critical thing in the management of a patient with STEMI is immediate reperfusion. And over the last couple of decades, there's been enormous efforts to try to develop systems of care to allow for this to happen more quickly. And so we talk about the period from symptom onset to first medical contact, and then that first medical contact to actual reperfusion therapy, and trying to minimize that door to balloon time, which refers to that first medical contact to reperfusion time. And so this algorithm comes from the 2013 ACCHA STEMI guidelines, which was the last time, believe it or not, that the STEMI guidelines came out. But I think it's actually a very useful way, a simple way to think about this. And so if we move to the left on the algorithm, if patients are initially present to a PCI-capable hospital, and with a STEMI, they should go straight to the cath lab. And the goal is to have their door to balloon time be less than 90 minutes. On the other hand, if we move to the right side of the algorithm, if patients are initially seen at a non-PCI capable hospital, the decision that we're tasked with is whether or not to treat them with fibrinolytics, clot-busting medications to try to dissolve the coronary thrombus, or to try to transfer them to a primary PCI center. And the decision there depends on how quickly you think you can get them to a primary PCI center. And the magic number is 2 hours, 120 minutes that appears in guidelines. And that comes from a database analysis from the National Registry of Myocardial Infarction from the early 2000s, which looked at mortality outcomes with various degrees of delays between door to balloon time and door to needle time. And so in general, if you can see that it was actually 114 minutes, which was rounded up to 120 minutes, but if the door to balloon time can be faster than that 114 minutes or 120 minutes, then the mortality is lower with primary PCI. If it's going to take longer than that, the mortality tended to be lower with using a pharmacoinvasive approach or fibrinolytics. And that's where that comes from. So if you're going to use fibrinolytics, the recommendation is to use a fibrin-specific agent. Half doses can be considered for patients who are older than 75 years. And then after fibrinolytics are administered, the patient should be given additional adjunctive antithrombotic agents, including an aspirin, a P2Y12 inhibitor, and an anticoagulant, and then should be transferred to a PCI-capable facility for potential rescue PCI. Important to point out that fibrinolytics only work about half the time, which is why it's so important to then, even after you've given that, transfer them to a PCI center. A couple things to think about is that when you're evaluating a patient with STEMI, think about symptom duration and as well as hemodynamic status. And so I've given you, what I've been talking about so far is the patient who presents with chest pain, ST segment elevations, and then you try to take directly to the cath lab. But sometimes patients present late. And so here are the class 1 indications. If a patient has a STEMI and their ischemic symptoms have been going on for less than 12 hours, they should go straight for primary PCI. If they have less than 12 ischemic symptoms for less than 12 hours and their there's contraindications to fibrinolytic therapy, they should for sure go straight for primary PCI, even if it's going to take longer than 120 minutes. And then if they have cardiogenic shock, kind of regardless of how long it's been since the onset of their symptoms, they should go straight for primary PCI. The benefit of primary PCI after 12 hours is somewhat diminished, although we tend to still treat these patients with PCI, particularly if there's any evidence of ongoing ischemia in that 12 to 24-hour period. And beyond 24 hours, there's a bit of a judgment call. And again, it often comes down to whether there's evidence of ongoing myocardial ischemia. One of the important developments over the last several years has been the movement towards complete revascularization in patients with STEMI. So patients who have ST segment elevation myocardial infarctions are then on coronary angiography found to have multivessel disease. The question, obviously you fix the culprit lesion, but then the question is, should you fix the other disease? Is that guilty by association? And so the largest trial to evaluate this was the COMPLETE trial, which randomized patients to either culprit lesion only PCI or complete revascularization within 40 days of primary PCI. So importantly, it didn't have to be done right at the time of the index PCI. And as you can see in the figure on the left, complete revascularization reduced the composite of major adverse cardiovascular events. And so now guidelines recommend using complete revascularization in patients with STEMI. The figure from the right is from a meta-analysis that basically looked at a number of different trials testing the same question and actually did show a reduction in mortality with this approach. And so, oftentimes patients will get revascularized, and then there'll be in some cases, they'll get upfront revascularization of their other lesions, and other times there's a discussion of doing staged revascularization. A quick word about the complications of myocardial infarction, which is often what lands people in the intensive care unit. So patients after MI can develop arrhythmias or conduction abnormalities. Ventricular arrhythmias are particularly worrisome, although very common in the early post-MI period in that first 48 hours. And so that we kind of attribute to kind of the early MI period. But if there's late ventricular tachycardia, particularly sustained ventricular tachycardia, that's associated with a worse prognosis. And so those are the cases where we do think about using either early implantation of a defibrillator or using VES to try to prevent sudden arrhythmic death after MI when it's sustained VT beyond 48 hours. AV block can occur after myocardial infarction. When it occurs after an IMI, oftentimes it's transient and related to ischemic and autonomic effects on the AV node. If it's after an anterior MI, usually that's a result of extensive myocardial necrosis, and so it's less likely to recover. We also worry about recurrent myocardial infarction, and that's why we talked a little bit about using antithrombotic therapies even after the stent goes in. And then the other thing that we worry about is the development of heart failure, of pump failure, and cardiogenic shock, which is most commonly related to severe left ventricular systolic dysfunction, but can also be the result of mechanical complications, including ventricular septal defects, free wall ruptures, acute mitral regurgitation, or right ventricular myocardial infarction, which can give different sort of hemodynamic derangements, but ultimately the same syndrome of cardiogenic shock. If a patient does develop high-grade AV block, we will often pace them. That can be done with temporary transvenous pacers or with external non-invasive pacers, as you see here. And so we'll pivot and talk a little bit about cardiogenic shock. There's another lecture as part of the series that's really a dedicated lecture about cardiogenic shock. And so this is just going to include some highlights. But cardiogenic shock is the most severe form of acute heart failure, and it's a syndrome of life-threatening end-organ hyperperfusion resulting from a low cardiac output state. And is the most worrisome complication of acute myocardial infarction. The clinical criteria are ones that have been developed in the context of clinical trials. And so generally we talk about hypotension or the requirement for vasoactive medications with evidence of hypoperfusion, so altered mental status, oliguria, cool extremities, or lactic acidosis. If a patient has invasive hemodynamic monitoring, then a cardiac index of less than 2.2 and a pulmonary capillary wedge pressure greater than 15 are considered diagnostic of cardiogenic shock. The only evidence-based therapy that we have for reducing mortality from acute myocardial infarction-related cardiogenic shock comes from the SHOCK trial, which is now 20 years old. What this was a small study of 300 patients that randomized patients to either emergency coronary revascularization or initial medical stabilization. And what the trial found is that there was a significant reduction in mortality at 6 months that continued, that persisted a year later and at 6 years later. And so it really sort of changed the field of the management of cardiogenic shock to really prioritizing emergency revascularization in any patient with an acute coronary syndrome, regardless of whether it's STEMI or NSTEMI, who is in shock. A follow-up trial from the last decade was the culprit shock trial. And so this question was looking at, should we upfront try to proceed with multi-vessel PCI in patients who present with acute myocardial infarction complicated by cardiogenic shock and then have multi-vessel disease, which was about 2/3 of the patients who were enrolled in the initial shock trial. And there were 700 patients that were enrolled, and they were randomized to the culprit lesion only PCI with the option of subsequent stage revascularization or immediate multi-vessel PCI. Interestingly, the patients had better outcomes if they just got culprit lesion only PCI and not multi-vessel PCI. And so the notion there is that, to get, fix the problem and then get out of Dodge and get people to optimal critical care shortly thereafter, but not to focus on multi-vessel PCI up front. Although the evidence-based support in the use of mechanical circulatory support devices is not robust, we do sometimes use temporary mechanical circulatory support devices for patients with acute myocardial infarction complicated by cardiogenic shock, rather than vasoactive medications, because vasoactive medications may not provide adequate hemodynamic support. They may increase myocardial oxygen consumption, and they may impair tissue perfusion. We use a number of different devices. The most commonly used device is still the intra-aortic balloon pump, which is a balloon that sits in the aorta. It inflates in diastole and deflates in systole, and that effect results in a decrease in left ventricular afterload, increase in coronary perfusion, which occurs in diastole, and leads to a modest increase in cardiac output. Importantly, there was a trial that looked at the routine use of balloon pumps in acute myocardial infarction-related cardiogenic shock, and there was no improvement in patients who were randomized to balloon pumps. And so the routine use of balloon pumps in AMI shock has been downgraded and is no longer routinely recommended. One of the questions is it just that balloon pumps don't provide enough hemodynamic support? And so there are a number of different percutaneous devices, including the Impella device and the tandem heart device that provide more robust hemodynamic support and are used for acute hemodynamic stabilization. Although trials demonstrating their benefit in this disease are ongoing, and we eagerly await them. Another modality that's used often in intensive care units, particularly for patients with biventricular dysfunction or who have concomitant respiratory failure, particularly hypoxemic respiratory failure, is the use of veno-arterial ECMO. And then just a final word about cardiac arrest in patients without ST segment elevation acute coronary syndrome. So when patients present with cardiac arrest, achieve ROSC, they often have an elevated cardiac troponin. The question often is, should we get this patient straight to the cath lab or not? And certainly if there are ST segment elevations on the ECG, the answer is yes, but there's now been a number of studies that have looked at what happens if there's not ST segment elevations, including the COAC trial and the recently reported Tomahawk trial. And to summarize the results of both of these trials, essentially they showed that there was no benefit to immediate coronary angiography in this group. Again, sort of focusing on early critical care management of these patients ends up being important, and it's not critical to rush these patients to the cath lab. And so in general, we favor a strategy of delayed coronary angiography in these patients. So in summary, the key points from this talk are it's important to distinguish between myocardial injury, which is reflected by an elevated troponin, and myocardial infarction, which is myocardial injury that occurs specifically in the context of myocardial ischemia. It's also important to distinguish between type 1 myocardial infarctions, which are primary coronary events, and those are the ones where we tend to, where we want to revascularize patients, as compared with type 2 myocardial infarctions, which is related to myocardial mismatches between myocardial oxygen supply and demand. High sensitivity cardiac troponin assays are now the favored assay for the evaluation of patients with suspected acute coronary syndromes. And then when it comes to the management, we break down patients into non-ST acute coronary syndromes for STEMI, NSTACS, the management is IV anticoagulant, dual antiplatelet therapy, and in most cases, coronary angiography, although not in all cases. In patients with STEMI, the key is immediate reperfusion, and primary PCI is the preferred approach within adjunctive pharmacotherapies as well. Cardiogenic shock is the leading cause of death following acute coronary syndromes, and early revascularization is really the only evidence-based intervention we have to improve outcomes in that condition. Although for acute hemodynamic stabilization, temporary mechanical circulatory support devices are used. And finally, for patients with cardiac arrest without ST segment elevations, the general approach is delayed angiography as opposed to immediate angiography. So we'll end with one final board review question. This is a 58-year-old woman who presents with substernal chest pain and dyspnea that lasts for approximately 24 hours. Her electrocardiogram, the electrocardiogram obtained by emergency medical providers en route to the hospital shows sinus tachycardia and ST segment elevations in V1 through V3 with ST segment depressions in leads 2, 3, and AVF. Her vital signs are notable for a heart rate of 118, her blood pressure is 82/64, and her respiratory rate is 22. She's awake, but her mental status appears sluggish. Her exam is notable for jugular venous distension and S3 gallop and cool mottled extremities. Her high sensitivity cardiac troponin is elevated at 688, and her serum lactate is elevated at 3.3. Which of the following is the most appropriate next step in her management? Is it A, admission to an ICU for hemodynamic optimization, B, administration of fibrinolytic therapy, C, emergency coronary angiography with plan for culprit lesion only PCI, or D, emergency coronary angiography with plan for complete revascularization? And so if you pick C, you're absolutely correct. This is a patient who is presenting with an anterior STEMI that was complicated by cardiogenic shock, and there's clear evidence of hemodynamic impairment and systemic hypoperfusion with mottled extremities and lactic acidosis. And so here, emergency coronary revascularization is indicated, not just because the patient has a STEMI, but also because they have cardiogenic shock complicating their MI. And as we discussed, culprit lesion only PCI is the preferred approach for the index procedure, and you fix the lesion and get out of Dodge as opposed to proceeding with multi-vessel PCI. Here are a few suggested references. Thank you for your attention, and I hope you enjoyed the talk.